Welcome, HAS class members this morning on a good Monday morning. We're happy to have you here. My name is Linda Fulton, and I'm a member of the Science, Medicine, and Technology Curriculum Committee. And our team is happy to bring you today's session on gender-affirming care. First order of business, I ask you to obey the 11th commandment. Please take out your cell phone. And the commandment reads, "Please turn off thy cell phone, for it is an abomination unto the speaker." Thank you. Welcome also to those who are joining us on Zoom in the HAS virtual classroom. And special thanks to Captain David Blatt, who's steering our technical ship this morning and supporting our hybrid modality. If you have questions and comments to pose at appropriate times, we ask for you to wait for the microphone so that everyone can hear you, especially those on Zoom. Online participants may share any questions in the Zoom chat, and our technicians will relay them on your behalf. A reminder, next Tuesday, April 2nd, is the first of 2 monthly programs in April. And next week's program is titled Defining Good County Governance. And yeah, it is presented by Eric Lufer, who is president of the Citizens Research Council of Michigan, and also Allegan County Commissioner Jim Story. Join us in person at the Miller Center for Musical Arts, where you'll find the usual coffee, cookies, and donuts beginning at 9 a.m. And you can also join virtually via YouTube. Stay tuned to the next HASP happenings for that link. And again, the program begins at 9:30 on Tuesday, April 2nd. At this point, I'm going to turn the microphone over to fellow HASP member David Moore to introduce our speakers today. David's was instrumental in connecting the committee with Linda and Wyatt, and I'd like to have David do the honors.
Thank you, Linda. It's my extreme pleasure. 50 years ago, a free clinic started in Chicago, Howard Brown Health Centers, which to this day has 19 sites providing care to gay, lesbian, trans folks across the city and the metropolitan area. I was a med student when that started, and David and I worked with that clinic over the years of our private practice in Chicago. At the end of that time, I worked there briefly, 2 years, working with transgender clients, and found it the most enjoyable and fascinating, interesting part of my medical practice, and a part of medicine that was very happy, which was lovely to do after the years of HIV medicine that we had done. Linda Wesp had been and gone by the time I came back, but her presence there was legendary. I heard about her from before I came and afterwards. So to have her come to talk to us today is a real pleasure. She's a PhD in nursing, as faculty at the University of Wisconsin-Milwaukee, and has recently contributed to rewriting the WPATH recommendations, which are guidelines for treatment of transgender people internationally. I can't imagine a better speaker. I'm going to let her introduce Wyatt. I'm really pleased and thrilled to have him joining us here today. Thank you so much.
Great, thank you. I'm going to go with my Britney Spears mic. Can everybody hear me? This is the first time, can you believe it? The first time I've used one of these, but it's very fun. All right, Wyatt, yes, you can hear us. I see you smiling. Great. So when David asked me to do this, I said, let me invite my dear colleague and friend and comrade. I think it's really important more and more as I do this work in these talks to not talk about trans and gender diverse people without them. And so I'm honored to have Wyatt in my life and as a comrade and colleague. And so he was the person I thought to ask. And so Wyatt, we'll do some more intros about ourselves, but he is a LGBT diversity expert. He is a respected and honored leader in the trans and queer community in Milwaukee, and someone who will be able to share his wisdom and expertise with us today as well. So thank you, Wyatt, for joining us, albeit virtually.
Hey, thanks. I think those were too many compliments for me all at once. So I'd like it if you were a little bit meaner to me throughout the rest of this presentation.
Well, let's go to the next slide real quick, and I'll just give people a sense of what we're going to talk about today. So Wyatt and I are going to tell you a little bit more about our stories and how we got to be doing what we're doing. I will give everyone a bit of an update about gender-affirming care in the US, which includes talking about the sort of socio-political legislative climate that we're facing at the moment, which we can't really do this work or talk about it now without talking about that. I'll talk a little bit about the latest sort of research and guidelines that David mentioned I had helped to co-author. And then we'll also share some data from a large survey that's just been released about trans people in the US. And then Wyatt and I will talk about some research we've done and some projects we're doing in Milwaukee, just to give you a sense of kind of what people are doing out there in the real world, clinicians and community members. So that's our agenda for today. And we're not going to do slides the whole time. So we're going to take the slides down now so you can just sort of see us. And let's see, we need to make sure we see Wyatt though. Let's see, how do we do that? Maybe we're kind of doing this on the, we tried this before. How do we see Wyatt in presenter view? Let's see. Yes, exactly. Yeah, great. We need to pin Wyatt up so we can see him. When we took the slides down, Wyatt went away. We tried this before and it worked. There he is. Okay, great.
So he's not gonna shift.
Yeah, he will again. Yep.
I have to clear them off.
Okay, cool. Great. So we'll get it sorted, you know? It's all, there we go. Now we got it.
Hello.
Perfect. Great. So I'm gonna, so Wyatt, let's have you start with introducing yourself a little bit and telling your story, and then I will go after you.
Yeah, absolutely. So hi, my name is Wyatt. I am a trans man. I use he, they pronouns interchangeably, so either is good. I am able-bodied. I'm a white settler of land-owning class with Irish ancestry. I live and work in Milwaukee, Wisconsin, which is on the traditional Potawatomi, Ho-Chunk, and Menominee homeland. More about me and my background. I am originally from Minnesota. I moved to Milwaukee in 2017 to study biomedical engineering at the Milwaukee School of Engineering. I did not finish that degree or any of the other 3 degrees in nursing or education that I've started. I have ADHD and it makes me get really bored the second that I start to get good at something, which is great. While I was at MSOE, I was actually in Honduras helping to run a medical clinic through a group called Global Grades. And one of the nursing professors there asked if I would talk to their transcultural nursing class about trans health. And I actually still go back and do that once a semester. I go and give about a 2-hour lecture to their transcultural nursing students. After I left MSOE, I became a 911 dispatcher and I developed an LGBTQIA+ 101 for emergency responders. And I have since presented that in 7 different states through the National Emergency Number Association, and then an additional 8 states for different local EMS agencies. Since I left 911 in 2022, I've worked for a medical supply company, and I still do regular trainings for emergency services, medical providers, and then some businesses around the Milwaukee area as well. In 2022 as well as when I met Linda when we were working at UWM on a sim for their nursing students in their pop health course. And I have like clung on to Linda and refused to let her go. And now we founded an organization together. And we'll tell you a little bit more about that later on as well. But yeah, that's me.
Awesome. Thanks, Wyatt. And as you heard a little bit from David, I I have a PhD in nursing. I'm an assistant professor at the University of Wisconsin-Milwaukee, and I ended up there after quite a long career as an advanced practice nurse. So I worked as a nurse and then as a nurse practitioner, mostly in Chicago at Howard Brown Health from about 2002 to 2012. And it was during that time that I really, you know, as a primary care provider in a community health clinic, was doing a lot of amazing work around HIV treatment, caring for LGBTQ community. And I saw at Howard Brown, when I started, I just finished school and evidence-based practices and protocols for everything. And I thought, where's the protocol for our hormone care? And it didn't exist. And I said, well, this is wrong. So I was like, there's got to be, you know, a more organized way that we could be doing this. And so I basically just sort of took it upon myself to make that right. And so through that, got very involved at the national level and then even internationally with others who similarly said, you know, it's not that there's no evidence and no research to do gender affirming care. We just need to organize ourselves and do the research that's needed and write the clinical guidelines that are evidence-based. There's been little to no funding for any of this whole time. So it's really been an effort of clinicians and providers, as David said, seeing anecdotally how important this is, and then trying to make sure we have the, you know, sort of evidence and structure around that for the work that we do. So that's really kind of where I got my start doing and developing my expertise in gender affirming care clinically. But I've always been someone who wants to be in and with the community, you know, not doing 2 people or 4 people, but with, right? And so that's really also led to some of the things that I was able to do both at Howard Brown and then when I moved to New York City and worked at Montefiore Medical Center, really to respond to what the community was needing in the way of healthcare and medical care. And through all of that, I said, well, I was seeing some research that was being done and I was like, I think I want to do that. And so that's what led me to get a PhD. And then also, to be totally frank, working as a full-time clinician burnt me out. So it was hard work to, you know, to see patients all day, every day, and the productivity and not really being able to do what I wanted to do for people and seeing the inequities. And that was tough. I've learned now as a scholar that they call that moral injury, that you see what needs to happen for someone, but the system and the structures are preventing you from being able to do that. And so I thought, well, maybe I'll survive this whole thing if I could become a researcher. So that's where I've landed now. I still do maintain a little bit of a clinical practice through a telemedicine clinic, like super part-time. And then do some community work in Milwaukee, and then working on my program of research and scholarship, et cetera, as a professor at UWM. And so that's sort of my story. I identify as a queer cisgender woman. I think it's important to situate myself in this space. I'm not a person of trans experience. I see myself as an ally and an accomplice. And I, you know, have plenty of privilege throughout my life, which means I bring a certain perspective as a white person, as a landowning person. You know, one of the things that I think is important as we think about gender and as we think about the ways that we are doing gender affirming care is that the culture we are all in is what sets the stage and the perspective for us around how we understand gender to even be. You know, all of us have been socialized in our sort of Western culture that gender is a binary thing, right? And that sex, biology is a binary thing. And both of those things actually are notions that are relatively new throughout history. That many indigenous cultures, from Native Americans in the US to other indigenous cultures across the world, have actually had much more of a spectrum understanding of gender than the binary, right? But that history is erased, it is not discussed. And so we have infused in our structures of our society this binary gender. What do? You check a box and there's usually only 2 of them, right? And that is very much how, and we all have actually quite a gender story. I've certainly been told there are things I should or shouldn't do because of my gender or what people perceive my gender to be. And all of us have that, actually. We've grown up being told we should or shouldn't do certain things. And so that is helpful and has been important for me as someone to unlearn some of the biases so that I can be present and not let that impact my work with people of trans experience or who are gender diverse. And so, so I think that's an important part to share as we kind of situate ourselves, you know, in the space. So I think we'll now this getting complicated because we'd like to put the slides back up. So let's see what happens, Wyatt, if we could do that. But we're gonna talk to you now. I'm gonna start by sharing a little bit about sort of yep, worked perfectly. So going that direction seems to be quite easy. Okay, so this is a map. There's a journalist who has done a lot of work to kind of organize the state of affairs when it comes to the anti-trans legislation. And what I mean by that are a variety of bills, mostly at all of them at the state and local levels that have been passed that are doing a variety of things. Everything from banning people from going into certain bathrooms to banning medical care being provided. And so this first map is to show you, so these laws and these sort of spaces throughout the country have been divided into safe places for trans people to be, and then unsafe places, sort of where the worst laws have been passed. And the top map was December of 2022. You know, in March of 2021, there were 0 laws passed, right? But by December of 2022, we started to see, and these were mostly targeted at especially banning gender-affirming care for youth and banning providers, clinicians from supporting youth or families to access any kind of support around a young person who might be saying, I don't feel comfortable in my body. I don't identify with the gender I was assigned at birth. I'm experiencing distress about that. If you're a provider in some of these red states, trying to help these families, you could lose your license, be banned from practicing, be charged with civil charges, etc. By June 2023, things got even worse, and you'll see Florida is a dark red color. And what that means is it literally says do not travel, because it is recommended that trans and gender diverse people who have who may have an appearance that doesn't align with the gender that might be on their birth certificate or a driver's license that may not align. It's actually recommended that they don't even set foot in Florida because it is unsafe for them to do so. They can be thrown in jail for up to a year for going into a bathroom that doesn't align with their chromosomes, which is a whole medical and scientific fallacy. It doesn't even line up for the way chromosomes necessarily work for all people because of people who are intersex. And so there's a ban on traveling to Florida, or a recommendation, I guess you should say, sorry, around trans people being in Florida because it's just not safe, right? And so if we can go to the next slide, the other thing that that Aaron Reed has done is sort of then had by 2024, so this year, we had and most of that was focused on youth, but now what we're seeing is bans on medical care for adults, and more states sort of bringing along. It's sort of like a recipe book that's happening with these laws. So one state will write one up, and the next state will just copy it and introduce it. And so we have separate maps for adults and for youth, because it is worse for youth, for sure. And of course, then for the parents and guardians of these youth. By youth, I mean people under 18 who aren't at the age of majority, although some states have wiggled that to be even up to the age of 21. Utah, for example. So it's becoming a more complicated situation, not just for youth and providers and families caring for youth, but also for adults. There's another few examples. So Kansas, Montana, Oklahoma, Tennessee have removed any legal rights that people have around self-identifying their gender identity. Other states are prohibiting people from changing birth certificates, and other states are keeping a list of anyone who has changed a gender marker on their birth certificate, so that they then have sort of a codified list of people's names and social security numbers who have ever made a change. And so this is the state of affairs. This is not proposed legislation. These are laws that have passed. You can see, of course, thankfully, we're up here in the light blue states for those of us living in Michigan and Wisconsin. I'm not sure about people online where y'all located, but so we're in a relatively sort of safer place to be at the moment. That is the state of affairs that we think it is really, it's impossible to talk about gender affirming care and being trans and supporting trans people without sort of setting that stage. And so I want to sort of have Wyatt share a bit now, if you'd like, about sort of what it's like to be a trans person amidst this context, living, existing, we're talking about healthcare, so trying to access healthcare and all of that.
Yeah. I wrote down a joke about a meme, and then I realized that maybe we don't all look at memes. But there's this photo that floats around the internet, and it's a cartoon dog holding a cup of coffee, and the cartoon dog says, "It's fine," except the entire room around him is on fire. And that's a little bit about what it feels like, especially living in a state like Wisconsin, or I grew up in Minnesota, where things are relatively safer, where it's like, okay, technically right now where I exist, everything is fine. But then you look around and the entire world is on fire, and everything's not fine. And if you so much as step foot in a different state, it can be very not fine for you. And it impacts, I mean, really everything. So the reason that I'm not there with you in person today is because last Monday I had a hysterectomy, which is super exciting for me. But like why I had a hysterectomy is because I'm not convinced that I'm always going to have access to testosterone or gender affirming care. And for me, a lot of the bottom dysphoria would come from menstrual cycles. And so I was like, well, if I don't have a uterus and they take away my T, I'm not going to have those menstrual cycles. And so at least I'll still feel okay if for some reason I end up living somewhere that I can't have access to gender affirming care. We have Linda and I both work very closely with somebody in Milwaukee who it's a trans couple and their daughter, and they have a daughter together. And we've had several conversations with them where they're like, we are getting passports and we're making a plan to get out of the United States now, because if things take a turn for the worse, we're afraid they're going to take our daughter away just because we're trans. Because there are states where they say that trans folks are not fit parents, where trans folks can adopt children. And even though this child is like biologically theirs, they're like, it very well may come to the point where they take her away. And so it's frightening to think that even in, Wisconsin, where we're safe, that these conversations are being had, and let alone places like Florida, where, I don't know, my family goes to the Keys every year. And like the last several years, I had to be like, I can't even consider going with you. And like that in itself is its own privilege, is to have like families who take vacations and families who are able to go and explore the country in that way. And then to be able to say, no, I can't do that, because if I go to Florida and like somebody hears me pee wrong in the bathroom, like I might end up doing time in jail. And that's just kind of a terrifying thought. And then we even get to, we're in an election year, and I think we're all aware of the two options that we're going to be presented with. But recently Trump came out with his list of top 15 things he's going to do when he gets back in office. And one of which is an executive order to ban gender affirming care for everyone. And we can go back and forth on the legality of that, but just the idea that that's something that in his mind that, just straight up across the board, no one's going to have access anymore. And what that looks like is terrifying. And so then it's interesting to then just go around and be like, yeah, I will take my bottle of testosterone, please. And the different, very like complicated emotions that come through with just trying to exist and getting access to healthcare at the same time. Linda, I have to imagine that things are not also great over on the clinician side. What is it like to be doing like prescribing gender affirming hormones and doing research at this point in time?
Yeah, I've said a lot lately, in the past couple of years that it's an interesting time because on one hand, which is the hand that doesn't that tries to make me feel some hope, we've come so far. I mean, from where we were when I started to do this work, from strictly a point of view of a clinician. We have so much research, so much data supporting what we're doing, such a solid evidence base and font of experience of providers, evidence-based guidelines that have been informed by community, people's lived experiences. So I feel like we've come so far in providing what I wanted, which in 2006 was high quality clinical care. Like that feels so good to me to be able to do. And now as an educator and someone teaching the future generation of nurses and nurse practitioners, it's amazing that I can present and no longer do clinicians have to say, I don't know what to do. Like we have solid, amazing base for what we're doing. And a ton of research and really exciting stuff that's happening. And a lot of information that's available and telemedicine and all of these things. And like, that's amazing. I prescribe hormones to people in the middle of Idaho right now who would otherwise not have access. Like we have come so far. And at the same time, I would have never in my wildest dreams imagined how horrible it would be at the same time. We as clinicians have been doxxed, which is when someone finds all of your personal information and releases it. There have been bomb threats to the gender-affirming clinics, and some of my colleagues have had to move because their children have been threatened. I get open records requests for my emails because I've been an author of the guidelines and they're trying to find something I might be saying behind the scenes. So that I just didn't know could even be a thing. Like I didn't know that could be a thing. But then I think about my colleagues who work in reproductive health, and it's actually quite similar to what people who've been providing abortion care have navigated for decades. And so but I just didn't think that would be me, but it is now. And so that is, something that you have to take in stride and figure out how to manage and survive and thrive. It certainly, as I mentioned before, creates situations for, again, not myself, because I'm not in a state where it's been banned for me to do my work, but for my colleagues, having to kind of make these complicated moral and ethical decisions about taking care of your patient and doing the right thing. But by doing that, you might lose your license. Right. And so how to do that and what that looks like is certainly a complicated thing. Even trying to refer a patient out of state in some states could be considered aiding and abetting. And so we're facing something that I don't know. I was naive to think that like that would be the thing, but it's the reality. And so, that's a piece of it. As a researcher, I've certainly heard in the academe tenure track world, oh, you're never going to get funded, to do your research. And I don't really care about any of that. I became a researcher because I wanted to do research with and by and for the community, not because I thought I'd get $1 million NIH grant, which I may not get, especially if things go a certain way in November. But that doesn't bother me so much. There's other ways to get support. I've gotten a seed grant from UWM right now to do some research that I'll talk about a little bit later. And I think, to me, I see this as an opportunity to sort of rise up in the face of the challenges and try to support community, support providers who want to do this work. That's been some of the most rewarding stuff I've done, is share what I've learned and what I know with other providers who want to be able to do this work. Because it is, as David said, some of the most rewarding clinical work that we can do. So that's sort of where, what it's like as a clinician. Thanks for asking, Wyatt. So we can see what happens if we transition again to take these slides down. Hey, perfect. So, just that's kind of the meme. I don't know if anyone's seen that, but having Wyatt, your head amidst the red states was sort of a good example of the meme of us both being like, it's fine. So within that context, I want to transition now to talking just a little bit about sort of some of the work I've done as an author of some of the clinical guidelines, and share with you a little bit some of the research that is out there. There's a tremendous amount of media coverage around gender affirming care, especially for youth, and not all of that is accurately depicting scientific studies. I mean, any of you who read scientific studies and peer-reviewed literature know that there's often a lot in that paper. And unless you really kind of understand like the methods and how the recruitment happened, it's really easy to take it out of context. So that's why in medicine we have what we call clinical guidelines, and what those are it's a process that's the same for the cardiologists and the urologists. When you have a bunch of evidence, you need to try to synthesize it so that the person with who's prescribing or who's diagnosing knows what to do. You spend a tremendous amount of time reading all that literature, getting a group of experts together, and coming up with a set of guidelines. And that's what we've done with the World Professional Association of Transgender Health Standards of Care. Now, they've had standards of care for decades. Up until 2022, those standards of care were primarily focused on psychology and mental health evaluation of people who were seeking gender-affirming care. But with the 2022 guidelines, it's now included a whole bunch of recommendations and guidelines around prescribing of hormones, around surgeries, and what it is that is appropriate to do based on the evidence, not just expert opinion, for providing gender-affirming care. So it's quite long. I have sent Ian, it's publicly available. So I've sent Ian a resource list, and on there will be a link where anyone can access it if you want to read all, I don't even know how many pages, like 400 or something, but it's 18 chapters. And it talks about gender affirming care for different age groups. The way we came up with it, and I was a co-author on the primary care chapter, which talks about, I'm a primary care provider. When do I order a mammogram for someone? When do I, how do I manage someone's cholesterol when all of our cardiovascular screeners require you to put in male or female? Right. And so real life on the ground, like, how do I do the best for my patient kind of questions? And we synthesize all the evidence and put that into the guidelines. So we have that now. And the other thing I want to point out, because a lot of the discourse in the media and a lot of the anti-trans legislation is pushing this idea that children are getting access to surgeries. We have separate chapters in WPATH standards of care for children versus adolescents. Children who are being affirmed in their gender do not have a need for any kind of medical intervention. It's not until people reach 10 or 2 of puberty, which is often when we see the psychological distress come about, that there is a bunch of things that people would go through for an assessment to be considered for some type of intervention, which might be puberty suppressing medications, it might be gender affirming hormones. That care for adolescents is rooted in adolescent expert care, the way we take care of all adolescents, which is generally best in an interdisciplinary team, meaning you have a nurse and a provider, advanced practice nurse, a physician, and a social worker, sometimes an ethics board that gets involved. And this is the same for all sorts of types of adolescent care that we provide, right? And so there's specific mandatory requirements that are set forth. And I think that some of the discourse is like, oh, this is just happening willy-nilly. This care is happening in academic medical centers with programs that are robust, which means it's not available to a lot of people in this country, even before the legislation. I mean, there's not a lot of spaces that provide this type of specialty care. But the specialty care has really sort of evolved and developed over time based on the research. And then in addition to WPATH, the endocrine folks who I love my endocrinologist friends, I've learned a lot from them. They have their own set of guidelines as well. So Endocrine Society writes guidelines about all sorts of stuff, you know, thyroid and diabetes. And they also have their guidelines for gender affirming care. And a lot of the recommendations really align. Sometimes these guidelines, just like other things we do in medicine, you'll have, you know, one organization set of guidelines comes out in 2017, another one comes out in 2022. So that one's a little bit more updated. And so that's kind of the case. Endocrine Society is revising their 2017 guidelines now, and that happens, you know, usually on a schedule like every 10 years or so. And so, you know, part of the other thing I want to sort of explain from a research perspective is we have ongoing research, you know, continuing. There is a ton of evidence supporting gender affirming care. Of course, there's always more things we can research, just like anything in medicine. And one of the critiques is that we don't have randomized controls trials. Well, that would actually be unethical because we have so much evidence about the benefits of providing gender affirming hormones, puberty suppressant medications, and surgeries, that it would be completely unethical to totally blind and withhold this care from a group of people just to see what happens. We have done that in a retrospective kind of way, just because of the fact that people can't access the care and been able to compare cohorts. And this is similar to other things in medicine. You can't always have a randomized controlled trial because you know something is working. And so you can't then ethically withhold that from a group of people. So what we will have and what we do have is a robust cohort study. You know, cohort studies is how we're really going to know what we need to know when it comes to long-term outcomes, best practices, different types of interventions, and all of that. And these studies are happening around the globe. There's a huge network in Europe called ENGI, European Network for Gender Incongruent Care or something like that. And they have put out a ton of data. In the US, a group was funded in 2016 to run a multi-site R01, which is like the biggest type of funding NIH puts out, to run a cohort study of youth under 18. And that it's in Boston, Chicago, LA, and San Francisco at some of the big gender affirming care medical centers. In 2016, after the election, their budget got cut in half. But they were still able to successfully enroll almost 500 participants that they're following, right? And so this is one of the first youth cohort studies that we have in the US. And they're starting now to put out some of their findings, some of their papers. So some of the things we're seeing, for example, now again, this is where you got to take it in context. These are youth who had consent from their parents, who got themselves to Boston, Chicago, LA, or San Francisco, had insurance that, you know, or somehow were able to navigate an academic medical center and get, you know, themselves in to the clinic, right? But even so, 66% of youth presenting at baseline had said they had suicidal ideation at some point in their life. 25% had attempted suicide. And these are similar to what we're seeing in just sort of other population-based studies, sort of the big CDC type surveys that we're doing. These are very similar rates of what we're seeing among trans and gender diverse youth. But again, these are youth who had support of their parents and showed up to the clinic and were, you know, getting the care and support that they needed. And then we're following these youth, right? So these youth are now getting, as appropriate, following the guidelines, various interventions, sometimes hormones, sometimes social transition and support. And we're seeing that what the mechanism of why people feel better, which Wyatt and I could probably say, yeah, we knew that. But, you know, the researchers are like doing surveys and asking all the right questions. The thing that is most impactful for someone's improved psychosocial functioning is what's called a conceptually improved appearance congruence. So when someone can be who they are and in their appearance that is congruent with their identity, they have improved psychosocial functioning. I mean, that's the whole premise of what we all knew. And now we have a bunch of data, you know, to support it, which always feels nice. It's like, oh, okay, that was good. And so we see, and then what does that mean? Well, suicidal ideation among youth after being on hormones for 2 years was 3%. It's not zero. It's still not quite as low as the general population, but it's significantly better, right? And so we know gender-affirming hormone therapy and medical interventions make a difference. It's not the only difference, but that appearance congruence makes a huge difference. But there's so many other factors, just like everything. Family support, laws that make it illegal for you to now get that care or go to the bathroom or bullying. All of these things are factors that we're having to navigate, especially for these young people who are just so resilient and beautiful in how they're able to do that. But I think, when we look to adults, the data I want to share is some data that just came out. There was a very large survey conducted called the US Transgender Survey. They've done it several times now, and they collected data in 2022. They collected data in 2022, and the early reports just came out a couple of weeks ago. They surveyed 92,329 people. This is it was a convenient sample. And so what that means in the research world is they didn't do like the random pick up the phone and be like, hi, are you transgender? Can you do our survey? They said, hey, trans folks, we want to hear from you. And so it was, people who identified as trans and said, yes, I'm going to do this survey. But it's providing us with some really important information to understand lives and experiences of trans people in the US. And also I meant to say there, just so people have a sense population-wise, we don't collect gender identity information on the census, so we don't have, that kind of solid, but the estimates are that somewhere between 1% and 3% of the population in the US is trans or gender diverse. And that's about the same equivalent of people who have red hair and people who have type 1 diabetes, juvenile onset diabetes. So just put it in perspective. So from the US Trans Survey, and again, this is adults, and they also included people who are 16 or 17, actually, so 16 and up. They asked for people who had transitioned or who were living in a different gender than the one they were assigned at birth. 94% that they said that they were a lot more satisfied, or at least more satisfied with their life, having now living in a gender that's congruent. 98% who received hormones reported that hormones made them a lot or at least a little more satisfied with their life. And 97% who had surgery said that they were at least a lot or a little. Now, the a lot part is usually around the 80 to 82 to 88%. And so if we compare that, for example, to like satisfaction, this is the way you measure stuff in medicine, like after knee replacement surgeries. It's like, are you satisfied with your life? And so the data after knee replacement surgeries, big systematic reviews, they've been doing this for years. The meta-analyses, all that is about 88%. So, this is, again, what we're looking at. We're not doing things to people who are like, oh, this was horrible, I'm not satisfied with my life. So these are things that people are seeking and things that are making them have an improved quality of life. So I got to talk about that good part, and Wyatt gets to talk about some of the other data that the USTS, so this big survey of 92,000 people, has found about, because you can be satisfied in your life and also experiencing a lot of challenges, right? Again, because of the dumpster fire part of what it's like. So Wyatt, I'll turn it over to you to share some of that. And also just, of course, your experiences and any of this that resonates for you.
Yeah, absolutely. I did think it was funny as I was like going down in our notes. I was like, oh man, Linda's sharing a whole bunch of fun stuff. And then I got to like my notes again. And I was like, oh yeah, I get to share all the sad stuff again. Because we are going to take a bit of a turn, because while, like Linda said, there are a lot of factors, and what we've shown is that like providing gender affirming care helps extraordinarily. When we turn to just like the socioeconomic factors of being trans, we get a little bit more on the sad side. About 80% of the adult respondents and 60% of the 16 and 17-year-olds who were out experienced some form of bullying or mistreatment related to their gender identity. And then more than 1 in 10 adults responded saying that a family member was violent towards them, and 8% of them were kicked out of their homes because they were transgender. And then 5% of the 16 to 17-year-old respondents said the same thing, that they had a family member act violently towards them, and then 1% of the under 18 folks were kicked out of their home because they were transgender. When we look at bathrooms, which is always a huge thing for trans folks, it said 4% of respondents were denied access to a restroom in a public place, at work or at school in the last 12 months. It's important to note that the survey took place before 2022, which is when a lot of the most severe legislation was passed. And then in the last 12 months, 6% of respondents said that they had been verbally harassed or physically attacked or experienced unwanted sexual contact when accessing or using a restroom. It's always like, sometimes when I give trainings, the bathrooms are always the part that people are most confused about, that people are having issues accessing the bathroom, because I think as most cisgender folks don't even really think about bathroom access as being a thing. But even going back to bring it to something more personal, I have personally been attacked twice in a bathroom. Both times were before I had top surgery, so prior to 2018. And when I tell the story, I always think I was like, oh, well, I was being dumb. I was traveling through states that I knew were not as welcoming. I hadn't had top surgery yet. It was 3 o'clock in the morning and I wasn't wearing a binder, which are all like justifications that a lot of trans folk makes, as in like, oh, it was my fault. I wasn't smart enough. And so then I was attacked, which is not true at all. Like those 2 times, once in Wisconsin and once in Nebraska, it was like 3 o'clock in the morning. I don't like to drive during the daytime. I like to drive at nighttime. I had to go to the bathroom. It wasn't safe for me to wear my binder for an extended period of time, so I had taken it off while driving. And someone in the men's room, so I used the men's room. I was generally faced with the decision of, I can use the women's room, but I also have a full beard, so I can make someone in the women's room uncomfortable, or I can use the men's room and potentially be unsafe myself. I don't like making women feel uncomfortable, and so I used the men's room, and those 2 times someone there was upset about my presence. Both times I was extremely lucky. I had some bruised ribs and a black eye, but those are the scenarios where trans people die in bathrooms. And so looking back on it, I got out lucky, but that's not always the case. Similarly, when we look at, so like I, as a now cis passing trans person who's white, have a lot more privilege in that. When we look at the experience of specifically like Black trans folks, 62% of all of the victims of fatal violence against transgender people were Black trans women. And that's a horrifying statistic. And then when we look, looks like between November 20 of 2022 and November 20th of 2023, 33 transgender and gender nonconforming people lost their lives to fatal violence. And personally, I think that number is probably a little bit low. I think that in the trans community, we do see a lack of reporting, especially a lack of reporting for violent scenarios. And then you have to also think that those are, again, only the ones that we know about. So those are the trans folks whose families also were like, yep, they were trans, or who were visibly out and trans in some way. And then the reporting followed along that line. At the time of this report at the time of the report, 26 of those deaths had occurred in 2023. And again, these are just the people who reported it accurately. The number is estimated to be undercounted. When we look at things like access to healthcare, again, nearly a quarter of the respondents did not see a doctor when they needed to in the last 12 months for fear of mistreatment. And that mistreatment can be a lot of different things. It can be like doctors just using like microaggressions, not using the correct name and pronouns, which when you're having a bad day, being misgendered in that way can be extremely harmful. And it can also be them asking inappropriate questions or them flat out refusing care. I have been lucky in that I've never experienced going to a doctor and being flat out refused care, but that is a thing that several trans folks experience. I have gone to a doctor and let's see, it was pre-COVID, so probably like 2019, I went into an urgent care to get I was pretty positive I had strep throat. So I went in to go get my throat swabbed for a strep test. And the physician who I saw there asked me if I still had a vagina. And I was like, bye. think that that's unrelated to my strep throat. But when faced with that question, it's just so like shocking that you're like, why is this important to my healthcare? And those sorts of experiences make trans folks not want to go to the doctor. We had 44% of respondents who experienced serious psychological distress in the last 30 days. And 79% of respondents saw a doctor or healthcare provider within the last months. Of those who saw a healthcare provider within the last 12 months, nearly 1/2 reported having at least one negative experience because they were transgender, such as like being refused care, being misgendered, or having a provider use harsh or abusive language when treating them. So those are all some terrifying statistics. And so we got that positive and the negative end of the coin, but I think it's important to also highlight, like, what are we doing now to try and make those things better? So I know that some of the things that I do specifically, we do those, I run LGBTQ plus 101 training sessions. I do those I focus on medical providers, emergency professionals, and then educators. I haven't gotten into a lot of just straight up educators, but I do a lot of emergency service professionals and then medical professionals. Generally, like I mentioned earlier, I do a few 101 training sessions at like MSOE. Linda and I have worked on a simulation at UWM. I've also done some emergency responder training programs, and that's generally focused on 911 dispatchers and then on EMS professionals. Every once in a while, I get asked to come and talk to police officers. It's always a really exciting day when the cops want me to talk to them about LGBTQ plus stuff, just because I feel like that is the community that has the potential to have the most negative impact on trans folks in terms of emergency responses. But yeah, with the 911, we talk about how to get correct pronouns, how to make sure that we're asking questions in an appropriate way. Same with same with paramedics. How to take a comprehensive patient history, how to ask and be sure, because a lot of times people are just afraid to ask questions. And then in that fear, they either don't ask and they miss something, or they ask in a harsh way that then doesn't allow them to develop patient rapport, which then is negatively affecting the rest of their interactions. And so we try and get a lot of those out of the way.
Yeah, and one of the things I want to add and then also ask, and we can talk about together, is like, I think with the majority of healthcare providers, nursing students that I've worked with, that we've worked with, the desire to do the right thing is there. But there's just, most people, I always say in my nurse practitioner class, how many of you learned about, anything related to trans health in your undergraduate, curriculum? And very few people, raise their hand, right?
Mm-hmm.
So there's this component of like sort of knowing where people are at. And then I think part of what we've tried to do, at least with the simulations with the undergrad students, is help people know what to do when you make a mistake, and set up the expectation that you are working within a system that's going to set you up to make a mistake. Electronic medical records are not gender affirming places. It's very difficult to figure out where to put someone's name that they're using, the pronouns that they're using, and see that along with everything else. One of the things we do in the simulation for the students is Wyatt plays the patient, and the nurse has to check the armband, which has someone's name on it and their gender marker, right? And so Wyatt, as the patient, says, hey, can you change this? Like, this isn't right. But your gender marker is usually in the EMR, has to be connected not to what your identity documents say, but what your insurance company knows your gender marker to be, because otherwise all the billing gets refused, right? So if your insurance company hasn't found the vortex of space where they change the gender marker in the data field, which for some insurance, especially Medicaid, is really hard. So like, I've talked to people at the state of Wisconsin, I'm like, can you allow this to be changeable? And it took them like years to allow that field to be changeable, So it's like, you have all the legal things that say but you have to be like this other gender marker, otherwise all your bills get denied. So what do you do? And so we, the nursing students are like, so Wyatt says, like, can I black Sharpie this out or something? Like, do you need to like see, do I have to see female on my wristband every day? And the nursing students sort of don't know what to do. But then what we now have is like you scan the wristband every time you pass a med. You don't actually, so we kind of help them think through, like, could you just black that out with a Sharpie if that would help your patient be feeling? Yeah, you could. It's okay. Can you help write a protocol for your floor that like allowed you to Sharpie out the little gender marker that's wrong? Yeah, you could, because does that matter? No, you just need to be able to scan the thing when you pass the med. So stuff like that.
Mhm.
I don't know if you can, and you fielded a lot, hundreds of questions from these nursing students, sort of what some of the most common questions are from healthcare providers that you feel like you're able to, help them navigate.
Yeah. Honestly, one of the biggest ones that I get in almost every sim that we did was, but how do I ask somebody what their pronouns are? Which is a big thing that's scary for people because it's just not part of their normal vocabulary. And one of the things that I always preach, I was like, well, if you're going to ask somebody what their pronouns are, you should always start with what yours are. Because otherwise, you're asking folks to out themselves to you. So generally, like when, I'm meeting somebody new and we're getting pronouns, I generally start with, hi, my name is Wyatt. I use he, they pronouns, what's your name? And like, can I get your pronouns or something like that? We do talk about the wristband is also another big one because a few folks get very concerned because they're like, well, this is a legal document. And then I'm like, well, if we're just scratching out the first name and the gender marker, well, one, it's not a legal document. And then two, if we're just scratching out like the first name and the gender marker, we still have multiple other identifiers on the wristband and the barcode because we're not doing anything to the barcode. What are some other big ones? I think that a lot of times the big thing in the sim is that we have a trans patient presenting with UTI symptoms, and they end up having pyelonephritis, and they don't use the bathroom at work because they don't feel safe to. And so then it's okay, well, how do we discuss pushing fluids when a patient doesn't feel safe in that way? And so it's a big conversation of like how to meet patient needs in a way that is going to be accessible and work for them. Can we push fluids only overnight? Can we give doctor's notes? What kind of doctor's notes can we give? And like, can we give multiple options so that the patient is able to decide what's best for them on any given day? Those are usually, that one and pregnancy tests are usually the other one that we run because we find it so common that when we're running a set of labs for a patient who has a female gender marker, they're going to have a pregnancy test run unless we like manually uncheck that. For me, like my gender marker at this point says male both on my driver's license and my insurance, but like if it didn't, and at this point I've had a hysterectomy and they're going to be like, well, we have to run a pregnancy test. I'm going to be like, for why? And this happens a lot for, trans men who haven't had their gender marker changed, but it also happens a lot for trans women who have had their gender marker changed. And so now we're running pregnancy tests on trans women who physically can't get pregnant. And that costs money to their insurance if they have insurance. Otherwise, it just costs money out of pocket. It's expensive and it's an unnecessary medical test. Why are we doing it? And so we have a lot of those in-depth conversations about how we can advocate for better care within the systems that have been set up.
Yeah, exactly. And to me, like we talk about gender affirming care, all of that is gender affirming care, right? So how can we help support our people who most of what people need is all the healthcare that we all need. But the system is not set up to really be a safe or easy place to get that. Unless we can make it more gender affirming. And so, a lot of that is what we really focus on when educating, healthcare providers to try to make, because you're still a human with another human in this system. And so there are always things you can do. And so, yeah, that's part of what we, kind of try to do. So with the last little bit of what we have kind of prepared to share with you, and then we'll have plenty of time for questions and discussion and stuff, we wanted to share a little bit about, some of the research we've been doing. One of the things that I have been very passionate about as I would become a researcher is to do what's called community-based participatory research, meaning that I would do research that was really something that community came and said, hey, we want to know this, instead of me coming in and saying, I want to know a thing about you. And so what we'll share a little bit is a survey that we did to understand what the needs were from trans and gender diverse people in Milwaukee. And this is, you want to share a little bit about how this even all kind of came about? We were sitting there at the sim one day and how you said, hey, I need to take my shot, and kind of how this all came about.
Yeah. So I, like many trans people, am really bad about taking my hormone shot. There's something about stabbing yourself that's just not fun. And so there was a day we were sitting in the sim one day, and I was like, hey, by the way, I need to be stabbed. Would somebody want to do that? And then Linda and I got to talking about this idea that had gone back and forth for a while about a place where trans folks can come and have volunteers give them their hormone injections. And while it was something that I was like, I know that I need this, I know that it exists in other places, but unless maybe it's just me in Milwaukee who's having issues with this, and unless we can find out exactly who else needs this form of assistance, or is this the actual assistance that they need, or is there something else? Is it, do they just need help getting the correct needles? Or what exactly resources does the trans community in Milwaukee need? And so we put together, and I say we, Linda mainly put together this survey. And then I went out and asked every trans person in Milwaukee to take it. And we hung flyers to see if we could get trans folks to come and take it. So that we could find out exactly what the trans folks in Milwaukee needed, so that we could build a community resource from there. And what we found is that, so we had 200 people who screened to take the survey, and we ended up with 129 who qualified and consented to taking the survey. Those who did not qualify were mostly due to age. We were looking specifically for trans folks over the age of 18. I think that we would love to provide resources to trans folks under the age of 18, but there are a lot of extra legality concerns around that. And we want to make sure that we can provide the best care possible to everybody. And so we were focusing on that over 18 group for the time being. And for anyone who screened out, resources and information was provided to the LGBTQ plus resources in Milwaukee. We have some of our results. What we found is that of the folks we interviewed, of the folks we surveyed, 74% of them were taking an injectable medicine. 11% used to take an injectable med, and 15% were not taking any form of medication at all. We also wanted to look at the barriers, what barriers are there for you getting your hormones. Some said, my insurance doesn't cover it. Some people said they didn't know where. My medical provider doesn't know what to do for me. Others were afraid of needles. And then we had a section for other barriers, which is like pharmacy barriers, refill denial, supply chain issues, things like that. And then we asked, what is the likelihood of you coming to a community space for supplies or for injection administration? And so we found that a lot of them said that they would come in for supplies. We had 17, numbers and math are hard this morning. So we had 17 who said they were extremely likely, another 11 who said they were somewhat likely to come in just for supplies. And then for folks coming in for injection administration, we had 20 overall who said they were either extremely or somewhat likely to come in for shot administration. We did have a few folks that they were neither likely or unlikely, somewhat unlikely, or extremely unlikely to come in. And then we wanted to make sure, like we said, we were focused on specifically the application of hormones, but we wanted to know what other assistance is needed for the Milwaukee area. We found that 103 of our respondents said that they wanted a community space to meet other trans and gender diverse people. 81, we had a community space with career or job resources, somewhere with food, written information about how to change my gender marker, someone to help me with that, or a lawyer to help me process these, legal documents. And that's those are the majority of the results of our survey. And so from that, I'm gonna take these down for a minute, but so from that, we built the Milwaukee Trans and Queer Depot. The Milwaukee Trans and Queer Depot is, like I said, Linda and I spent a ton of time. Also, we have another sorry, my screens are all sort of weird here, trying to make it so I can see all of the things. So the Monkey Trans and Queer Depot, Linda and I spent a ton of time on this. We also have another provider who helps us set up and run these things, Dr. Melissa Melcher. What it is, it's a mutual aid, all volunteer, community-driven organization. We meet weekly on Wednesdays from 3 p.m. to 7 p.m. We have all of the injection supplies that you could need to take gender-affirming hormones, needles, syringes, multiple types of needles and syringes, alcohol swabs, Band-Aids, gloves, and we provide all of that for free. We also have various volunteers who will come in and give folks their gender-affirming hormone injections. If we are going to be the ones giving injections, we generally have someone fill out a waiver just to make sure that we're covering all the things on our end. And then we have them fill out an intake form. It's the only time we ever ask for an ID, so we can make sure that the ID on the prescription matches their, legal ID. And then we never have to ask for it again. If folks are just coming in for supplies, anyone can come in for supplies. They don't need to show us their ID. They don't need to fill out any form. They can just come in. We can help them pick out supplies. We can teach them how to do shots in the way that is like safest and best for them. We can talk about, how the pros and cons of sub-Q versus IM. If you ask me, anytime I give myself a sub-Q injection, I'm going to stab myself in the spleen. I'm aware that that's physically impossible, but it's what's going to happen. And so I have to do IM. Then we also, we wanted to respond to the rest of the needs that folks talked about. And so we are a completely sober community space. We had several respondents talk about, Milwaukee is very big on, beer and alcohol culture. And so there were several folks who were like, well, we want a sober space to hang out where we are not going to be pressured into those situations. So we said, great, excellent. MTQD is a sober space. And that's just going to be what it's going to be. And then we also try and right now monthly do a food night. Sometimes it works out to more to monthly. Sometimes it works out to we have to miss a month. And that's also all volunteer driven. We've also done a passport night. So we had volunteers come and we had a photographer and various computers and printed out forms and people to just help folks fill out passport information. And so that was for brand new passports. And it was also for gender marker changes on your passport. And someone would just sit down and help you fill out the paperwork. And then we'd print out the paperwork for you. We'd even give you an envelope and make sure it was addressed. Don't tell Linda, mine's still right here. It hasn't been mailed in yet. But no, I didn't. I'm so sorry. I lost my checkbook.
Fine. That's why we're gonna have another passport night in May for everybody to get back. Did you mail it in?
Yes. We're having another passport night in May. We're super excited. Yeah, that really is a lot of it. Is just making sure that there's somebody there to help hold you accountable for the things that you want to do and need to get done for yourself. Also recently partnered with Vivint, which is a local it's a local medical org in Milwaukee focused on HIV health. But they're going to come in and start doing on-site HIV, Hep C, and STI testing. We have another org that comes in usually once a month or so to help people change, fill out gender change paperwork. We have the ACLU coming in to help people register for voting. We have volunteers who want to run a nature walk once a month. And so he comes in and he leads a nice little walk about a mile and a half or so around Milwaukee and try and get to some of the green spaces. I've done so much talking about this. I'm going to let Linda jump in.
Yeah. A couple other things about MTQD, Milwaukee Trans and Queer Depot. The space that we use is in a church. So there is a church that is a beautiful space that's across the street from UWM's campus. It's not on campus. And the pastors of the church are both queer and trans. And they have really opened up their space as somewhere that is safe for us to be. As much or as little as we want to be there. I mean, I feel like we could probably be there every day and they wouldn't mind. It's just we can't be there every day. And so that's been huge. That really has felt like we're able to be in a, honestly, a religious institution that's protected from all the things, which is kind of lovely. So, we feel like that's nice for us to be able to be there. And first, we were a little concerned because we were I'm not sure, well, people are going to want to come into a church. There's a lot of religious trauma and issues for people in the trans and queer community. And so I don't know if we know who's not coming because of that. Like we haven't put out survey, but it is sort of the community space, like to the side of the church. Like people don't have to like walk up the steps, like through the pews. It's like a side door. So I think that helps a little bit. And it's a huge rainbow flag out front that says, God loves you. And, so it's like, so sometimes I think for some people that's helpful. And then, probably for the people it's not helpful, we don't really know because they probably haven't come yet. So
true.
one of the things we're, looking at is like, how could we also be in another space? What does this look like? But as a mutual aid org, we're doing what we're doing because we have people in the community showing up to do it. This isn't like the Linda and Wyatt show, although we are committed to making sure someone is there every week. So, at this point, it's at least one of you or me or Missy who's there to at least unlock the supply room. But we really don't have an agenda except to hold the space for the community. And so people have showed up and brought things and offered to do talks and brought in the food and suggested ideas. And that's great. Like we want to do all the things that community needs. And what else was I was thinking of one other, well, and the same thing goes for the actual injection support. And what I'll say is as a provider, so I was a provider at a clinic in Milwaukee for quite some time until I just like couldn't work 3 jobs. So I let that go. But one of the things that was happening is I had a whole bunch of patients who been on hormones for years, developed sort of a needle phobia, weren't able to give themselves their shot, and would come in to see me in the clinic every week for me to give them their shot. The clinic I worked in was sort of like it was like a semi-free clinic. They were sort of, so we just didn't bill people's insurance, and we were able to kind of get away with that because it was such a small operation. But people who go to FQHCs and medical centers, every time you walk in the door, you're going to pay a copay. I mean, everything's got to get billed. So that just isn't sustainable for people who need support for them to come into the medical system. And that's what we're finding is, so what I was hearing from my patients is, well, when I'm like, well, what do you do when you can't come in here? Well, I have my friend give it. Or my friend, or my friend is has people over in her basement every week to like help each other give their shots. And so, and then I met Wyatt. I was like, oh, they do this in Minneapolis? Like people in Milwaukee need this because I see them. And I don't know what's going to happen when I leave this clinic. Where are they going to go for their shots? So now they're all coming, so it was a need that we were both seeing from our different sort of positions. Me as a clinician and sort of Wyatt as someone who needed it, yourself. And we really did model it after what they were doing in Minneapolis, which is where you originally, found out that this was a thing.
Yeah, absolutely. So when I started hormones, I drove up an hour and a half from my like hometown in Mankato to the Twin Cities to meet with a gender therapist there, who was really in OBGYN, I think was her actual job, because I had my appointment canceled one day because she got pulled into an emergency C-section. And I was like, all right, I didn't know that this is what we did. I thought that you were just gender stuff. But so the first day that I went in for my appointment, she gave me the bottle of testosterone. And she was like, here's a flyer for this organization. Go talk to them. They'll teach you everything you need to know about how to do your shot. And so I got a flyer for the Minnesota Transgender Health Coalition. And thankfully they were open that day, and I went over and they got me set up with a sharps container and needles. And then I got to get my first T-shot from a trans person who was a volunteer there, who was like, okay, this is how we do this. This is where you can inject. This is the best way to do it. Here's how you draw up the things. And that is, so then when I moved to Milwaukee, I was like, well, obviously Milwaukee has it. Milwaukee and Minneapolis, they're on the same level. And then Milwaukee did not. And so I'm super excited about the fact that and it really wasn't until I met Linda that somebody was like, yeah, we should do this together. Let's build it. And so now it exists. And now I actually remember there was a day that a trans person who had just gotten their prescription that day came into the depot, and it was a day where Linda and Missy couldn't be there. So it was just me by myself. And I got to do this. And I remember texting them and being like, oh my God, I just did this thing with 17 crying emojis. Because it was just so it like felt so full circle that I was like, I had this experience and now I get to create this experience for other people in Milwaukee. And like, it's just such a magical thing to be able to do.
Yeah, it's super cool. We opened last June, so we haven't even been around for a year. We don't, quantitatively keep track. People are, how many people? I'm like, we're just there and people come if they need to come. But I know for Passport Night, we had at least 30 to 40 people in the room. And I mean, we certainly have a regular, set of 5 to 10 people who come every week. And, probably up to 100 at this point who've gotten support in some way, shape or form, either through our TikTok Q&As, which is why it's specialty. Social media is not my thing. Or from just coming in, getting supplies, getting education. We have a little fake injector thing so we can teach people how to give a shot, what I would use for the nursing students. And so, it's certainly meeting a need. And that's what, for me as a clinician, it has actually been healing too, because I'm like, oh, I can actually help people. I'm not within the system where there's harm that's happening by the time people get to me. It's like the whole thing feels good. And that's super cool. And so I'm working on fixing the system still. I'm trying to teach the nurses, I'm trying to do the research and the policy and all that stuff. But this is like 4 hours a week where I'm like, this is always going to feel good, because people aren't going to get misgendered. They're not going to have a front desk person do something. They're not going to have the wrong thing. It's just a completely sort of barrier-free space for people to actually get the immediate thing that they need. And that's super cool. So for me, it's kind of come full circle too, which is awesome. So I think we have plenty of time now, 15 minutes or so, for any questions, dialogue, thoughts. So we'll have a microphone. Linda's going to be our mic runner.
Does Holland have a plan and a place for people to go? Yes.
That's a great question. I don't
And
know.
I belong to a church that's based on room for all. And we really believe this and try. And I know we have had visitors probably keeping warm inside. I don't know the details, but I keep wondering how, as a community, what we can do and how aware we are.
Do you need the answer? Okay.
And yes, please keep doing it. Thank you. All communities and all spaces, however big or small, need to be creating safe and supportive spaces. So thank you.
I'm sorry, but the mic system, it's hard for
Hard to
me to
hear.
hear you sometimes,
yep.
and I have hearing aids, but it's turned out quite well.
Right. Yep.
I'm a 73-year-old, and it would appear to me as an outsider that this is a fairly recent phenomenon with people having gender dysphoria and wanting to do transitions. I mean, the famous one when I was growing up was Christine Jorgensen. I think that was back in the 60s, 70s, maybe. So is there any data that shows that, okay, there's a sudden spike in this kind of thing, or is it just been underreported all these years?
I think it's multifactorial. So anytime you think epidemiologically, my brain goes to like, well, what's the cause of the thing, right? And I actually, as I kind of alluded to earlier, prior to sort of white colonial settler culture in the United States, most indigenous cultures had a diversity of gender. So there was not a need for people to have a gender marker assigned at birth. People could be two-spirit or of a third gender. And then, so when that became suppressed, we have definitely seen less people because people were sort of forced into being, expressing a gender identity that aligns with the sex you were assigned at birth. Then people, that doesn't fit for everybody. That's not new. So the fact that people experience an incongruence of gender is not new. It's the fact that society has such strict boxes that is what became new. And so then really you start to think, well, what's the cause here? Well, the cause we could say society's the cause, but how do we change all of that, right? And so now we're at the point where I think in the late 1990s, early 2000s, there has been this effort to support people to be authentic in who they are. And that has looked like supporting people accessing these different types of gender affirming treatments. There have been plenty, and there are plenty of people who do a lot of advocacy work, who are really expressing themselves. Alok Manon is one. I can send his name out, but Alok has done a lot of work in just a diverse gender expression, not necessarily taking any medical intervention, but being someone who's very comfortable expressing gender that for people who are used to a binary sense of expression doesn't necessarily align. Maybe having facial hair and wearing a dress, for example, which most of society would not be necessarily accepting. And it's not very safe for someone like that to move through the world, right? So I think it's so multifactorial. And I think now what we've seen is that people accessing gender affirming medications and surgeries is certainly on the uptick. Why? Because there's access to it, there's support and information. I think people who come to see me now and they're 60, 70 years old, they will say to me, I know this has been true for me my whole life, but I'm just able to finally start these hormones now. And I'm finally able to do this now. Sometimes it's because a spouse passed away and they didn't want to upset their life, but now they can do this because they feel like they have the space in their life, to do that. Sometimes it's because they've seen people paving the way and there's more visibility and support in society now for people to be not necessarily cis and in the binary gender all of the time. I don't know, Wyatt, if you have any other thoughts.
Yeah, no,
thoughts on that?
I do. I think it's interesting too, because a lot of times we'll see, like with the younger population, we'll see especially like a higher proportion of that population identify as LGBTQ+. And I think that is, like Linda said, for a lot of reasons. But part of it is again that like the language is there. And so now people who are younger and younger are able to put their feelings to a word and describe it, actually. Because like even when I came out, I didn't come out until 2016. And when I came out, I knew one other trans person. And there still wasn't a ton of information that was like easily accessible for me to figure out, what is it that I'm feeling and how am I feeling it? And like, does this have a word? Is there something wrong with me? But now people younger and younger are able to like have those feelings and then also reach out and experience other people having those same feelings and talk about it and be like, okay, so there isn't anything wrong with me. There are options to move forward from here. Here are things that I can do and like what feels good for me and how can we move forward in a way that is like safe and accepting, which is really exciting.
Hopefully that answers some of the questions.
Yeah.
Yes.
Oh, where to begin? I know our transgender adopted son looks pretty much like Wyatt. Full beard, breasts are gone, but still has the same fears when he travels, especially public bathrooms. And that's something that is always on his mind, like what if, because it could happen. And one thing I have heard about support in Holland is I have heard that Holland Hospital is very supportive, but I don't have any proof of that, but I have heard that Holland Hospital is very supportive.
There are a couple questions from people at home. First one is about this person is familiar with the guidelines you've been involved with, Linda. She's perplexed regarding the backtracking by some European countries as it relates to gender affirming care for kids. And particularly she's perplexed because it seems to be driven by clinicians, not politicians, although politicians here use that in this negative trans work campaigns they wage. So this person's interested in your comments about that.
Yes. So there's a pretty, and I'm not, I don't have that all at my fingertips, but one of my colleagues, Paula, who does a lot of work at Hopkins and is a lawyer, she has a really good depiction of kind of how this has played out. There are certain people and clinicians who are the same people and clinicians who are the voices for this movement to ban gender affirming care. So the sort of the attacks on trans people, there's like a kind of like a playbook that they have. And so like if we can find someone who had been taking hormones and then stopped, and if we can find clinicians and providers who maybe had been doing this work and then decided to be the ones to kind of speak out, that's what's happening. So it's the same few people and the same sort of playbook that they're using in Europe and in the US. And it's actually some of the same coalitions behind all of it, who are naming themselves all sorts of things. There's the, I never want to get it wrong because it's so similar. It's like the American College of Pediatricians. And they're actually pushing a very specific agenda to, you know, a whole host of things around not teaching kids about sexual health and, you know, chromosomal alignment for gender identities and, you know, reporting any young person who talks about sexual orientation that's not heterosexual to their parents, you know, all of this sorts of thing for as guidelines for clinicians, right? So it's a very small but strategic group of people who have sort of planted and are working with these same clinicians and, you know, patients to kind of push this agenda. And it's the same groups behind what's happening in Europe and here.
Another question from home was about how you view transgender people and their participation in athletics.
We knew we were like, we'll probably get the question about sports. It's a really broad question that's actually quite nuanced and complicated. So and Wyatt, we get this question a lot when we teach the nursing students too. Like the way one thing I want to always try to say is like hormones, so estrogen and testosterone, when it comes to like blood levels of hormones, are extremely variable across all human beings, regardless of whether they're cisgender or transgender. Physiologic, athletic eliteness is also extremely variable across all human beings. So there's certainly advantages that come from people who have more muscle, who might have larger bones for certain sports. None of that happens to any human until they hit puberty, right? So when we're talking about children who have not started puberty yet, there's physiologically like nothing that's different, except for how someone's been socialized, of course, right? Which does do something. Once people hit puberty, if you put someone through a puberty that is testosterone based, whether that testosterone came from within their own body or from outside, their body's gonna do the same thing. So there's just no difference. And the same is the case for someone with an estrogen-based puberty. So someone who may have been born with a penis and testicles and identifies as a trans girl and got put on puberty suppression and never had testosterone in their body and was put on estrogen, that person's bone structure, muscle mass is going to be the same as they would be if their body was creating and producing that estrogen from inside. They just happen to have a few extra body parts that are doing nothing because they've been shut off and we're giving them estrogen from the outside. So I like to paint that physiologic picture so everyone understands. Of course, it gets more complicated for adults and people who have transition, and then you're like, but don't they have an advantage? And blah, blah, blah. And so that's the case also though for people who are intersex. And so we have a society where we've put sports into two different categories, and there have always been people in the middle. Michael Phelps is like superhuman in his ability to hold oxygen in his lungs, and we did not ban him from swimming. You know, so those are my thoughts. I think there's also like plenty of evidence, and sort of what some of the research is trying to do is show the psychosocial benefits of team participation in sports. And when we're banning trans kids from being able to do that, it's having, just tremendous amounts of sort of psychological detriment for their psychosocial development as kids.
The last,
My question relates more to the white privilege of it, where Wyatt was able to have surgeries. What happens in a more underprivileged community where they identify differently but don't have access?
It's interesting that you brought this up because, Linda, I don't know if Cameron talked to you about this last week. Cameron's a member of our board. He recently had some conversations with some Black trans folks in Milwaukee that we're going to go back and have further conversations on so we can figure out how to meet their needs, because a lot of the responses were, it's great that the white trans folks can have a shop clinic when we can't even afford hormones. And so there is a lot. But the main answer is that they just don't get access. And that's a really frustrating thing that we're also trying to counteract in a lot of these ways, is making sure that everyone does have access to gender affirming hormones and gender affirming surgeries. In Wisconsin, it can be especially difficult because, while we do have a state healthcare system like Medicaid here, Badger Care here does cover some of those hormone treatments and surgeries, to have access to Badger Care, you have to make well below the poverty line in amounts of money. And so then it's like, okay, well, I'm making too much money to afford Badger Care. And I want to say like below poverty, like I think Badger Care cutoff is at like $15,000 a year. So like an astronomically low amount of money. And so you're at this point where you're like, well, we're making too much money to afford healthcare, but the job that I'm working doesn't give me insurance, and then I can't afford this out of pocket. And so, at least like from my experience and interpretation on this, unfortunately, it's that they don't have access, which is why it's really important when we're having these conversations to point out the amount of privilege that someone like me as a trans person who, while still experiences some of these hardships, is still set levels above, other trans folks who don't even start to have access to this care.
Yep, the structural racism issues are impacting certainly people's access to all types of healthcare, including gender affirming care. And then of course you also have implicit bias within the healthcare system when people are trying to access care. Wisconsin is a state where the legislature is run by Republicans, so we have not had Medicaid expansion, which is why it is so difficult to access Medicaid. They've left billions of dollars on the table. That being said, we also used to have a state level law banning Medicaid from covering anything around gender affirming care. And I am proud to say that I was part of the expert witness testimony that got that overturned. And that was an effort between 2017 and 2019. That the same day I defended my dissertation, we won the lawsuit. So I was like, that was a good day. And so we used to have a situation where even if you could get Medicaid, it wouldn't cover the stuff, but now we're good. And that has remained untouched. It used to be that state employees also had a ban on their insurance from covering gender affirming care. And we also got that overturned, and that has stayed untouched. So, there's all sorts of layers of effort and things that need to happen to sort of dismantle the barriers. Some of it is we just need people to go vote. Well, how do you get people to go vote? Well, we need them to have an ID, because we also you have to show your ID to vote in Wisconsin. Well, how do we do that? Well, we have, so there's like layers of barriers, right? To keep trying to get the legislature to expand Medicaid. And then that would make things very different, I think, for a lot of people.
I think we've about run up to the end of our time, and I certainly would like to thank Linda here in the classroom and Wyatt on the other side of the big lake for sharing your research and your work and your experiences. And if anybody has maybe additional question, I don't know if you'd be able to hang
I'll be
around
here.
a bit. So,
Sure, for sure.
so
Thank you. We'll get you the mic.
I would bet that there are people who don't know what cisgender is.
Cisgender is someone who, cis is the Latin word for the same side or same as. So cisgender is someone who has a gender identity that is the same as the gender and sex that they were assigned at birth, and maybe is also congruent with how their body is appearing from, and moved through life from birth through puberty. Whereas transgender is someone who has a gender identity that is different from the sex or gender that was assigned at birth. Thank you for asking. Great. Thanks, everyone.